Hello and welcome back to another episode of Diabetics Doing Things. We are telling the amazing stories of people with diabetes from all over the world. And today, all over the world is, I think, a really key term because we are talking with Emma Klatman. And Emma, you are in the UK, you're from Los Angeles, and you work for an organization, Life for a Child, which is based in Australia. So you live a global life, to say the least. Welcome to the show.
Thank you so much, Rob. Thank you for having me on the show. Been admiring the show from afar for quite some time, so it's wonderful to bring the global perspective onto the show.
Well, I'm excited to dig into that with you today because I think early on, I think maybe one of the first internet social media advocacy challenge is not the right word, but like campaign would be the right word that I was invited to, and Diabetics Doing Things was invited to. Is in like 2018, we got invited to the Spare a Rose campaign,
Mhm.
and that was to, I think it's still going on. It's the Spare a Rose on Valentine's Day in favor of a donation for Life for a Child, which I think we're going to talk about is one of the more creative patient advocacy organizations who kind of comes with these really out of the box solutions in places where there really isn't a lot of diabetes innovation, education, or advocacy, like kind of are forgotten. And I think in the West, we talk a lot about insulin affordability and patient advocacy, going to the doctor, and and making sure you advocate for yourself with your employer, and these types of things, which are very important and critical issues. But when you're talking about just getting access to test strips or just insulin in general without having to, walk or hitchhike 40 miles outside of your town or something in West Africa, for example, these types of things we don't always think about because they're not as, as close to our day-to-day life here in the US.
Yeah, just on the Sparrows side of things, Sparrows is an incredible community-led initiative that has supported Life for a Child for a significant amount of time. But when the Ukraine war broke out, they shifted they shifted focus and started fundraising for insulin for life, which we at Life for a Child have a very strong relationship with. And when it comes to, I don't want to use the word solve, but when it comes to utterly inadequate provision of very basic diabetes care in low and middle income countries, there is no one global group. There is no one even local institution that can solve everything. And that's why, when Sparrows shifted to insulin for life, we were, of course, saddened to lose out on the community awareness raising and, of course, fundraising. But Insulin for Life is, a phenomenal, phenomenal group. And it's the ecosystem of, global networks that devote their time to increasing access to the basic components of diabetes care. That collaborative approach is really key and crucial.
It is because I think there's so many hurdles and barriers and regulatory and even in the US, simple things like shipping insulin. And during the pandemic, I know that there were challenges as well with making sure that with insulin for life, like that donations could be cleaned adequately and were didn't sit too long and in the wrong conditions. So anyway, lots of hurdles to get through to get patients what they need. And like you said, there is no one single governing body that can just distribute those things. It really is a network of community members.
And
So
and I wanted to, sorry to interrupt, but
yeah,
I just wanted to pick up on one thing you said earlier about, you know, when the COVID-19 pandemic was as, proliferative as it was, and in the height of everything, I think I'm not sure if it was the head of the WHO who said that COVID-19 is sort of the great equalizer, or maybe non-communicable diseases are the great equalizer that unite us, no matter where you live. And I think there's merit in saying that. But at the same time, I do not think that type 1 diabetes is the great equalizer. I think it can be within, certain environments and contexts. I'm sure you and I, have a lot of common ground and relate to a lot of the same things. But, having type 1 diabetes in Los Angeles, and of course, taking into account like, different, socioeconomic, conditions, but having type 1 diabetes in, Los Angeles is not the same thing as having type 1 diabetes in Accra, Ghana, or, so many other places. And I think that, when you look at the numbers just of how many people have type 1 diabetes globally, the large majority of folks are living in those low income settings in low and middle income countries. So I think that, we kind of want to rethink a little bit that whole great equalizer perspective. Yeah, at the same time, there, I think, are different, there are different rungs to that advocacy ladder, and there are different rungs to, advocating for yourself within the clinic. And I do believe there is commonality there, but it's about, what existing capacity, is at the starting point in the first place.
I'm glad you brought up this point, and I do want to talk about your life with type 1 diabetes as well. So we will get there. I promise, listeners, we will get there. But from that perspective of, type 1 diabetes not being the great equalizer and it being very different from for a person in Los Angeles or in a developed city in the West versus, I think you said Ghana. We also have talked, about Eritrea herself is very passionate about Eritrea, the country, and making sure that we see people there as well, because in third world or emerging nations that are war torn or just do not have the infrastructure, there are people with type 1 diabetes there. I often think about, when I just do thought exercises, thinking and acknowledging that there are people with type 1 diabetes in places like North Korea, where we don't really have visibility into what their life is like. And that I want to layer that on top of what we know and have discussed a lot of in this podcast, calling type 1 diabetes the disease with too many inputs, and acknowledging location, socioeconomic status, government as some of those inputs. And it's different than just, GDP per capita or whatever the case may be. It is, truly, what infrastructure does my location where I was born, you know, those of us in the West really don't acknowledge very often. I don't think that we won the genetic lottery in terms of
Mm.
where we were born at a particular time. And so I just want to acknowledge that as well, as that, like, there's so many other inputs that even though we see a host of 185 or so inputs in the West, that there are more that we just take for granted on a day-to-day basis simply from infrastructure.
And like that brings up another angle to this, which are the social determinants of health, of course. And just when you were speaking about this, a past International Diabetes Federation president, Jean-Claude Mbanya from Cameroon, he said that accidents of geography, and like you were alluding to, they are indeed accidents, or it is kind of an exercise of a lottery, but accidents of geography should not determine whether someone with diabetes lives or dies. I would say that disturbing, awful, avoidable situation is lessening today. It's not like how it was 10 years ago. Things are getting better. Deaths from misdiagnoses or lack of diagnoses, that is narrowing. Education is growing, around public awareness and DKA prevention. So I think things are getting better from a survival perspective, but it's about, Life for a Child's vision and mission is around no child should die from diabetes. And while, that is a destination that we are getting closer and closer towards, I think, the next kind of frontier is, children become adults. Of course, that's not life for a child's, part of life for a child's mission. We are focused on children and adolescents and young people under the age of 30 in low income countries. But I think the next frontier really is, how are we addressing all of these advances in glucose monitoring and ensuring that that gulf and sort of that two-track system, unfortunately, between high income settings and lower income settings, how are we working towards, making sure that gap isn't going like that and instead narrowing that gap more so? Just a few, when I first started at Life for a Child, one of my first research projects was on scoping the global market for meters and strips, because I know in the US, access to insulin is the more expensive component of care, comparing that to, access to your traditional meters and test strips. But in low income settings, ironically, it's sort of the inverse. And meters and strips are just, utterly cost prohibitive. I could dig out some figures, but in 2012, Life for a Child did a study on the financial impacts of type 1 diabetes management. And I think 2 test strips a day in, you know, I think it was in Burkina Faso, it was like 327% of a family's, annual income. It might not be exactly that amount, but,
I
it goes
remember
to
reading a
show.
similar study about Ethiopia, and it was like the cost of diabetes management was 50% of household annual income, and that was 1 test strip a week, like a extremely low quality of care.
Exactly. And we haven't yet solved, globally since the marking of the 100-year discovery of insulin. There's been a lot more momentum, and I'll give credit to the, global health community on the advancements that have been made in terms of setting the global health agenda when it comes to advancing, provision of diabetes care in these, in vulnerable populations, which are the majority of populations, if you think about it. But test strips, not so much of a priority. And so one of those early papers that I wrote was on, global access to meters and strips. And at the time, the pervasiveness of CGM provision and access to CGMs, like it was a completely different time. And now, jump to 2023, that's now standard of care. But at the time when we wrote the paper, we had a line in there that said, we're not worried about the sustainability of, folks being able to access meters and strips because type 2 diabetes will kind of always provide a safety net. But
Mm.
as we see, CGMs being used more and more widely within the sort of holistic diabetes population and in the wider, general population as well, it is one of those things that keeps me up at night, worrying about, technological phase outs and how can we really, ensure that people with diabetes in these settings continue to have access to not just insulin, but test strips and all of the other things that, keep them afloat from day to day and not just surviving.
Well, that I think speaks directly to that gap between haves and have-nots that you were talking about earlier. Even just a personal anecdote, I wear a CGM that no longer requires daily calibrations. And so my test strip usage has dropped off compared to pre-CGM is, I use 1 test strip a week compared to 10 a day sometimes. And so that multiplied over time is a significant decrease. I fill maybe 1 prescription of test strips now per year compared
Mm.
to, 12 every year or so. And so then I started to extrapolate from that on the market implications. And so, in the US, we just do everything is a business. So we think of it that way. But the market cap of test strip companies has dwindled significantly because of the rise of CGM. And on the have side, you might say, okay, well, that's just the creative destruction of the economy as we know it. That's innovation. That means that we're moving forward. But on the opposite end of that spectrum, for people who never had adequate test strips and don't have access to the cost or the money to get a CGM or even a cell phone that would need to link, to make it usable, those people sort of get left in the wake. And I think when we think about health equity, something that we've learned at Diabetics Doing Things, in particular over the past year and a half, is that health equity starts with awareness and information, and then moves into, like, like you said, like there's fewer people dying because of misdiagnosis. That's because of information share and top level awareness. But that's just the first step. The next step is, okay, well, what is the access question to the standard of care that we're very comfortable with here in the West, and we sort of take for granted, of 8 to 10 test strips a day, CGM every 2 weeks or 10 days, and pumps and smart insulin pens and like the very top end of the technological spectrum. Whereas our brothers and sisters in Burkina Faso and Sri Lanka are still very much on Lispro and syringes and maybe a test strip.
Mm, yes. I think perspective is, I mean, just kind of changing track a little bit. Perspective is kind of, from I think actually up until recently, a lot of people that I work with globally didn't maybe even realize that I had type 1 diabetes because I wasn't having just marked 25 years of living with it, because I think I kept it, I I kept it maybe under wraps, or I was very professional about it. I'm not really sure what the terminology is for that one, but I think,
I don't want to interrupt you, but I
please.
I identify very much with that. Um, Most people I interact with that aren't, my Instagram community or, my close friends, like they would have no idea that I have
Mm,
diabetes. Even people that I play basketball with on every Saturday, and my insulin pump is always on me and my CGM patch is on me. I think, they don't know that. And I think being a professional, professional diabetes decorum, where, I don't know. I want to dig into that because I think it's interesting. Like, my first 10 years with diabetes, the only thing I really wanted people to know is that I was going to take care of it. And I
mm,
think that, yes, hey, I have this thing, but it doesn't have me. I'm going to, whatever we need me to do, I'm going to be able to meet the needs for that. And I think it wasn't until this podcast where I kind of raised my hand and said, hey, I am a person with diabetes, and I want to share that part of myself, that more people started, hey, like, I didn't even know that any of this was happening. This is really interesting. And so, yeah, I want to dig into that because your life is in advocacy. Your life is in awareness, and you are actively advocating for people with diabetes all the time. But that manifests itself for you in different ways.
mm. I think like this is so multifaceted, and I've actually never like really publicly talked about this with anyone, let alone a stranger, you, which hopefully one day I can call a friend. But I think for me, when I started out with Life for a Child, I came to the role having just completed a master's in health policy reform. And I think I felt really scared. And I felt this fear that this first really serious job of mine wasn't based in merit. And it was just because, like, oh, she has diabetes. We need that value add.
Hmm.
And I don't think that was a real external voice. I think that was just an internal voice coming from myself. Just to give a little bit of background. So I was diagnosed when I was 7. I started advocacy very early on in my life. And, like advocacy has a bajillion different meanings. I think that's what's makes advocacy so honestly beautiful. But I started like a lot of public speaking advocacy, like poster child advocacy. At a young age, I had a doctor, Dr. Francine Kaufman, who was,
Oh,
you
I
know,
know Fran. I know
oh,
Fran.
everyone knows Fran. She was just so utterly connected. And I was a very like fiery, vivacious, kind of snarky little 7-year old with diabetes. And it was my greatest dream to like be an actress one day. That was never going to work out for me. But I think she saw that I had this, like I like to be on the stage and I like to convince people of things. And I was very gobby, like I like to talk a lot. And I think she saw in me that I could do something with that skill or characteristic of mine. And eventually I became the national youth advocate for the American Diabetes Association. And rest in peace to Senator Dianne Feinstein, who passed away. But I was just looking at a photo on my phone, sitting outside her office in Washington, D.C. And I was doing a lot of speaking to politicians, trying to increase, funding for, at the time, the big thing was around funding for a cure. And I did that type of advocacy probably throughout high school. And then I went away and, went to college, did a little bit of work and, pursued this master's. And I really just pulled out hard from the whole diabetes advocacy stuff. It really wasn't of interest to me anymore. I honestly felt like I just kind of washed my hands clean of it. And so when I became very interested in global health and policy from that perspective. And when I realized there was, an intersection between diabetes policy and global health, I jumped at it. I didn't come at my role in Life for a Child as this sort of like advocacy angle and advocate that I am now. I very much feel like I'm like returning to my younger self. Okay, I've learned a lot more. I'm, a bit more pragmatic and strategic, and I've just experienced some more life, as you do getting into your 30s. But I feel really good coming back to that, younger advocacy self and the kind of Emma advocate that existed in the interim. I think she was just learning her place. And, when I joined Life for a Child, you know, engagement of those with lived experience was not super common. I think, from my perspective, that was something that I saw more in the US. That's only becoming more and more common kind of in global access. And that's something that I've been pretty unapologetic about in terms of not just inviting or involving the lived experience as a sort of window dressing exercise, but to keep, people with lived experience at the forefront of the decision making process, not just, placing them at the beginning of this sentence or as a period or exclamation mark at a global stakeholder meeting, but actually meaningfully engaging them. And I think, you know, I've I've really advocated for, real people to be represented in those meetings, not just someone like me who's, yeah, I have a good
Or
vantage,
me.
but I'm very privileged. And so I think I think I've done quite a bit there. And I've also, and this is something I'm still working at, is, getting healthcare professionals that I work with to really empower the people that they care for. And that is a really hard process.
I love this topic because what comes up for me recently is we're in this age of patient empowerment, and I think we're sort of in globally this like empowerment of the individual. You see it in other areas as well, sports, commerce, business, you know, individual rights. And
Mm,
with patients, I think it's so important because like you said, in the US, we I think take it for granted a little bit that like, patients are more involved. But like you said, globally, especially on issues of policy, healthcare providers and researchers are leading the way, but there isn't necessarily that person with lived experience there. And if they are, they're someone like me or you. And I think it's funny. I identify with younger Emma being like a poster child for, hey, diabetes. You can do whatever you want with diabetes. You can, it doesn't have to stop your dreams or whatever the case may be. And I think as I've gotten older as well, being more careful with my language of making sure that doesn't exclude people who, are more disabled by their life with diabetes and who have been stopped at times by things and who don't have the same privileges that I have. And I think that inclusive language and that sort of has really changed how we do things around here. And I'm sad Eritrea isn't here to add to this because I think she was a big part of it as well, is making sure that our good vibes don't exclude people who don't feel that same way. And on the other side, I think I was at a board meeting I'll say it, I was at a JDRF board meeting a few weeks ago, and I was the only patient in the room, and I felt really uncomfortable. For the very rarely do I feel uncomfortable in a big room full of people, especially around diabetes. But it occurred to me that the decisions being made on behalf of patients are happening with or without us in the room. And at first I felt uncomfortable, and as I started to think through it, I'm also in my 30s. I'm going through, sounds like the same thing that you are, of like just learning and growing and getting older and like learning
mm,
from a lot of life experience. And I was able to kind of grow through in the 30 minutes processing these feelings and say, okay, well, if these decisions are happening anyway, I have asked to be here. I need to live with and become more comfortable with the fact that this is why I'm here. It feels uncomfortable because if I wasn't here, no one would feel uncomfortable. And now,
mhm,
okay, well, as a patient, how do I get more people through here? Because I think a common feeling for patients at specifically in the nonprofit world around fundraising is that they feel like the most important people at the fundraiser are the people who are giving all the money. And we kind of, some of us get paraded around and our amazing stories and pull heartstrings and help people donate to the orgs. But what I want to encourage people who are in those situations, who are patients and feel like they're uncomfortable or feel like they're maybe not in the right place, I would say that you are in the right place, that we still are very early into this. And since those decisions are being made with or without us, shouldn't we, do our best to get as many of us in those rooms as we can? And over time, more of us will be there, and therefore our voices will become more unified, and we'll be able to get some of these issues that people who don't live with diabetes will never really understand or may just forget.
mhm. Yeah, I just resonate a lot with what you said. And, like I was saying earlier, I'm not sure if this was being recorded, but, it's only recently that I also have these feelings of discomfort, and they're really uncomfortable to sit with. And I know that this is a tall order. And sometimes when you're like flooded with emotion during, really, you know, these uncomfortable moments where you feel like you're the token voice or the only one, and, you hear something and you scratch your head and you go, is that really, the way that we're talking about people who live this day to day? I know it's a tall order and, I have been trying to do it a little bit more, but voice that discomfort. I think voice that discomfort like to the room that you're in, because I think there's no, this is going to be, I'm going to talk about positivity a little bit more after I finish this point, but at the risk of sounding overly positive, I think there's no shortage of goodwill amongst like the global funding network for type 1 diabetes. Those that I work with, stakeholders, funders, they're some of the like most empathetic people that I know and real problem solvers. And I think that a lot of times people who don't live it day to day don't, can they can miss points and they can forget certain things. And I think I'd like to think that all of these wonderful, stakeholders and funders would appreciate, the honesty. I'm not sure everybody would agree with me on that, but I have been trying to do that more. It's scary. It does does give a little cortisol dump for me that my glucose levels don't thank me for later. But I'm just trying to, in this kind of new era of my diabetes advocacy, just like go forward as fearlessly as possible. Like, the old phrase, be afraid and do it anyway. Just check my fear at the door. I'm always going to be scared about something, but deep down, I know what I'm standing up for is the right thing. And I can go to sleep at night knowing that I've tried that day. But on the whole, like not being overly, if, optimistic about or painting advocacy as just like this cheery, wonderful, you can do anything you want to kind of narrative. Obviously that's important. And young people should be told and encouraged to do, what they want and go for things in life because young people are like sponges. You know, you tell them you believe in them and they believe in themselves. So I think that that's important. But at the same time, personally, and we at Life for a Child, we're very conscious of that whole like toxic positivity stuff. And I have to say, that's one of those things that, sometimes can be injected into, diabetes advocacy in the context of resource limited scenarios. And it really does my head in. Like, it really annoys me because it's just so irrelevant. And so I think, you know, recognizing, where people are at and meeting them where they're at while, tapping into other kind of options for being positive and hopeful about life with diabetes, like peer support. Not necessarily you're going to, be able to do what you want, be, a doctor, an astronaut, or get married. Those are not all things that people with type 1 diabetes are going to be able to have. And that's just a fact. So I think like leaning on facets like peer support can be really important. And I think, on the whole toxic positivity stuff, that sounds like a really bad and dirty word, and it sounds like, you know, that would include like sinister kind of activities and behaviors. But even like toxic positivity to me is like telling a patient who lives in, Southeast Asia, for instance, where that sort of dynamic between patient and doctor is very strict. And it's very like, they're like, the doctor is, a figure of authority and deserves respect, So to be able to, to hear someone tell an advocate tell a patient, stand up for your rights, like, don't,
Hire your
don't
doctors.
let them. I mean, it's just, it's just totally unrealistic. And I think ultimately, like, you put the person with lived experience, in an unsafe place and like a very lonely place. So I think just the whole like meeting them where they're at, that's something that we at Life for a Child have always kind of been guided by, whether that's in the clinic or whether that's in advocacy. It's hard and no two situations or countries are alike, but different cultures plus diabetes, you're always going to get really differing scenarios.
I want to talk about a little bit of of some of the projects that you and Life for a Child have done that really stand out for you in that same context? Because the way that I was introduced to Life for a Child, I guess in like the professional or like industry background. So my dear friend Tom Shear, rest in peace, introduced me to the Life for a Child team, and I think it was 2021. We're looking for young ambassadors. I guess I checked the young box still at that point. I feel like I probably don't anymore. But and like, how do they get more into the community and that type of thing? And so I had a conversation, and the way that he presented the work that you do at Life for a Child was just getting very creative about solving, you know, problems in places that most people don't think about. And so I'd love to hear from your perspective, how some of those advocacy efforts manifest themselves. And when you think of some of your most impactful or favorite advocacy efforts from Life for a Child, like what comes to mind?
So I will just preface my answer and in this and saying that like advocacy isn't sort of the main dish that Life for a Child serves. Primarily it's about getting supplies to where they need to be, logistics and coordinating, which I guess you could classify as advocacy as
I
well. And
do. I think I consider that advocacy in its like most, I guess, grassroots form is like just
Mhm.
getting people what they need.
Okay, so let's go from there then. Life for a Child is managed out of Diabetes Australia, and but at the same time, Life for a Child is, we're a very small team. We're a team of 11 people. And somehow, we're able to, have such a fantastic, phenomenal, large reach, actually impacting lives. At the end of 2022, we were supporting around 45,000 young people with di- you know, intermediate level of diabetes care in around, 40 odd countries. And we have pledged by 2030 that that number will increase to 150,000 young people. Part of that increase in number will be, increasing our reach within countries and countries where there is a high incidence and there is a big population. So, like Ethiopia, Eritrea, Bangladesh, and then also commencing support in countries where we are not yet providing support. So I think, just thinking about some of like the biggest kind of program moves for Life for a Child in the last year, we have always only been able to provide diabetes care to those aged 25 and under. It's not a perfect scenario, but young people, people with type 1 are, typically diagnosed in their younger years. And we all know just how important it is for young people to get a good start in life. But earlier this, I'd say about 6 months ago, with the support of Eli Lilly and also our logistics partner, Direct Relief, we were able to expand support to those under the age of 30 in low income countries only. Now, it's a little bit confusing, but the World Bank, they're high income countries, but then there's upper middle income countries, then there's lower middle income countries, and then there's low income countries. And for Life for a Child, that means, about 17 countries we support are low income. So that means that those up to the age of 30 are now, going to be able to continue the support that we provide to them. And again, like it's not a perfect solution, but for, countries and clinics we support in countries where there are fallback systems, like for instance, in Rwanda, there is a health insurance fund called the Mutuelle de Santé. And the Mutuelle provides human insulin 90% of it is covered by the system. And just put to the side for a second, not a large majority of the population can't even afford enrollment fees. But for the ones that can, it is, a sliver of diabetes care that you can count on. And so those extra 5 or 6 years, gives young people supported by, let's say, the Rwandan Diabetes Association to be supported in vocational training programs so that they can afford enrollment fees. And then I'll just say on the pure advocacy front, the thing that I'm most excited and most impacted by is something that's super topical, actually. And I'm not sure if you've heard of them, but they're the Changemaker projects that we launched about a month ago. And the Changemaker projects are this is an initiative that Life for a Child introduced 1 month ago. And 6 people affected by type 1 diabetes in the countries we support in Latin America and Africa will receive funding, a mentor, and networking opportunities to be able to push, a high impact community advocacy initiative forward. But also, it's rooted in a systems approach too, because we want to be able to, build capacity, advocacy capacity in countries and in, contexts where the advocacy capacity isn't that strong. Just to give you an example, in East Africa, the sort of non-communicable disease type 1 diabetes advocacy network it's not, mushrooming, but it's built up a bit. But in West Africa, in, North Africa, in certain pockets of the continent, not in sub-Saharan Africa, there are no sort of known advocates. And, I truly believe that change starts with individuals. And we really underestimate, I think, the resilience and natural problem-solving skills that people with diabetes have in terms of driving change forward in their settings. And I don't think that sounds too toxically positive, to kind of go back on myself, because, we're really meeting young people where they're at. And that's our approach there.
I agree with you. I don't think it's toxically positive. I think it speaks to the potential of the impact that someone with diabetes has. And I think that is something that I don't want to lose, even, while critiquing and in some cases condemning some of the toxic positivity language. The idea that a positive mindset with diabetes can serve you better than the opposite, I think there's for sure clinical outcomes to support that. But I think, even just emotionally, holistically, there is potential for people with diabetes to do whatever they want, even if what they want to do is change the world for other people with diabetes. So I would encourage people to not, it's at the fringes where things get crazy. And I think the truth is more in the middle, is that, you can have a positive outlook and advocate for people who are suffering from diabetes in a different way.
And I think that can look different in so many different ways. Like for me, the most at home and rewarded and sense of community I've ever felt, when it comes to diabetes is when I have put, my efforts into trying to build other people up, because it always comes back to you. And the feeling that you get building others up, at least for me, is, that makes me feel like the cards that I was dealt with diabetes are we all have bad days, but on most days, it makes me feel like the cards, I was dealt are kind of worth it. Even if it's just someone responding to a question I have in Omnipod Reddit when I feel like throwing my PDM out the window, or, saying at a global meeting, why do you have me, Emma, a white chick here? Please get someone who actually has lived experience in the context we're talking about, give them the stage, and it's just about yeah, meaning. And that's how I take meaning from it.
I also think that just building others up, like forget diabetes, forget advocacy, whatever, like that outlook, building others up is will serve you so much better. So many more things will come back to you if you do that. And if you have that sense of collaboration and teamwork. And that's the thing that I like is sort of non-negotiable for me in my
Mhm.
professional and personal relationships is I have to have a shared because if we have that shared value, then what can't we accomplish together? I think is the way I look at it. I want to ask you something because this is something I've been thinking about, and you strike me as a thinker. You're right, we are strangers, but this has been really good. I look forward to hopefully continuing to develop a longer term relationship in the advocacy world. But insulin was it's 100 years. We've heard it. We're in year 101 now, or whatever the case may be. Which strikes me as two ways. The first is that if you and I were born at any other time in the history of the world, we'd be dead. So, like, how lucky and how fortunate, like, what a weird juxtaposition that is from how, difficult a diagnosis in a life with diabetes is that the only other alternative, up until 100 years ago was death.
Mhm.
And the second piece being that we're only 100 years into life with diabetes, and that there are only a handful of advocacy organizations and only a handful of podcasts and advocates because there has not been an opportunity for that we really are in the early stages of breaking new ground. And in that way, I feel uh, that we've accomplished quite a bit. Yes, there's a long way to go, but the people that I see and the projects that I see coming forward right now are the first of their kind, and they sort of don't exist without the people behind them being the change. And so just want to know your perspective on both of those things and then we can kind of wrap up sort of the interview today.
Hmm. That is honestly a lot of food for thought for me because I don't know, for me, just on a personal note today, I haven't had the best diabetes day. I just switched on to an Omnipod 5 and the algorithm is learning me and I feel very much like, why aren't things better? But then I hear you say, okay, well, it hasn't actually been that long. It's been 100 years. And in the grand scheme of things, 100 years is like just nothing. And
I have to just interrupt because I
yeah,
think
yeah.
this I'm super nerdy. So I read this idea that if from the time of recorded history was a 200-page book, that the last 100 years, the last 200 years would be one page. And you think of
Mhm.
all that humanity has come through in that amount of time from 1820 to 2023. And, would diabetes even make the list of all the things that we've accomplished, and in that time? And I think that, again, like it really hasn't been that much time. So anyway, I'm a nerd. Sorry to interrupt you for that.
No, no. Well, I'm gonna up your ante in the nerdness because sometimes, especially at night, if I'm like stargazing and stuff, and I like look up and I like I've had this happen, a number of times this year. I don't think about this all the time, but I look up and I realize, gosh, just how, small I am, just how small Earth is, just how small this solar system is. And anyway, it's just kind of part of the same sort of thing. So, when you going back to it, like when you look at just how much has been accomplished, like even in the last 5 or 10 years when it comes to diabetes, I mean, I'm sure a lot of people, young adults can relate when I say this, but like diabetes management and technology it's unrecognizable today as opposed to how it was when I was growing up. And I think you change. I've changed a lot in that time. Like every young person, I can remember like asking my dad in the hospital when I was diagnosed, like, when is there going to be the cure, Dad? When is there going to be the cure? And he gave, the sort of normal answer 10 years, maybe 15 years, maybe 20 years. And honestly, Rob, I don't really spend much. I know some people do. And I respect it, but I don't really spend any time at all wishing for a cure with a capital C. I spend my time thinking about like that sort of lowercase c cure, which for me, I see that as, continual access to all of the incredible technological advancements and interventions that are coming out, that will come out. I feel, as, sometimes harrowing as it is to kind of really look deep down at, access globally, I think good things are on their way for many different contexts, different environments, different socioeconomic settings. I have to kind of remain positive about that because, from a survival perspective, but also I think it's true. I think that good things are coming. And do I think that the, two track kind of access gap is going to, fully narrow overnight? No, I think it will always be there. I think it will always be there. But I'm just concerned about what are our plans for tomorrow and how sustainable are our approaches? How thoughtfully are we thinking about sustainability here? And I think just to bring it back to what you said earlier, I think I am always going to sort of live a double life, having diabetes and working in diabetes in the context that I do. And there's nothing wrong. There's nothing wrong with, you know, having being able to live in a country or a city or a setting where you have access to care, but then you also work in a context about, you know, just keeping, survival guaranteed. I think that does strengthen your approaches if you come at them empathetically and are thoughtful and question things. I think that that kind of two world thing can actually strengthen, our perspectives. And there's room. There's not just room for your context of how you live with it. Think about think about other perspectives and, it will help your own. And I think vice versa.
I think you're totally right. And I think that awareness and that curiosity makes you stronger. And I think we can all do better to think about what it's like to walk in someone else's shoes. And that doesn't negate our own experience either. Our You can live in the most well-equipped, well-outfitted, well-resourced country and still struggle to live with type 1 diabetes because it's hard. And I think, just acknowledging that you're not alone either. And, we have brothers and sisters in under-resourced, terrible situations that they unfortunately were born into by no, and, by that terrible luck, like you talked about earlier, that
Mhm.
unfortunate lottery. But remembering them and bringing them up and giving them access to the table and platforms in these discussions, I think can, have broad sweeping change. So thank you for the work that you do, even walking those kind of double edges as a person working in diabetes and living with it. And, for those who want more information on Life for a Child, it's lifeforachild.org, and some really amazing stuff going on all over the world. So, Emma, thank you very much for your time today. It was great to meet you. I'm disappointed Eritrea wasn't going to be here because I know she was so excited for this interview. So, we'll definitely have you back. But this was, I also did not have the best start to my morning. And this kind of really turned it around for me. So thank you for your time. And yeah, this episode was produced by Eritrea Musa. It's edited and published by Ashley Bright and Exhale Creative. DJ and Corey do an awesome job on our social media clips. So we'll see you guys next time.